So I think we'll make a start today. So good afternoon, everyone, and welcome to today's webinar. This webinar is brought to you by Fiocruz, the Global Consortium for Injury Research and the Global Health Network. My name is Dr. Becky Brown, and I am with Dr. Jack Denny from the University of Southampton in the UK. And we are delighted to be joined today by Dr. Michael von Bertele and Professor Christiane Andrade. This Research and Focus webinar focuses on supporting traumatic injuries research in resource-limited settings.
Traumatic injuries disproportionately affect resource-limited countries, with 90% of both injuries and injury-related deaths occurring in LMICs. While we have seen global responses to pandemics such as HIV and more recently COVID-19, traumatic injuries account for around 11% of the current global burden of disease and nearly 5 million deaths per year. Despite being one of the leading causes of death worldwide, and with an annual increase in debilitating injuries, not enough is being done to address this pandemic. In this webinar, the Global Health Network brings together experts in injury to share experiences of conducting research in resource-limited settings. Participants will learn how to navigate practical research challenges faced in conducting injury research and conduct high-quality research. So before we begin, we've got to run through some housekeeping. Firstly, this session is being recorded and also streamed live on Facebook. The recording will be shared in the coming days on the Global Health Network platform so you can review the materials and share. To interact with the panel, please use the Q&A and chat functions, which you can find in the toolbar within Zoom. If you have any technical issues, please let us know in the chat and the Global Health Network team will aim to assist you. If you'd like to ask a question, please do so in the Q&A function at the bottom of the screen. We have a dedicated time allocated for Q&A, so we'll try and get through as many of those questions as possible. But if we don't have time for all those questions, we will save them and try and get written responses along with the recording at a later stage.
So we will now begin the programme for today. Firstly, I'd like to welcome Michael von Bertele, who is retired Director General of the British Army Medical Services and latterly Humanitarian Director of Save the Children International. He has broad general experience of planning and delivering health services in a range of settings and has a particular interest in the longer-term impact of conflict injury on civilian populations. Over to you, Michael.
Thank you, Rebecca. I'm just going to share my screen with you so that you don't have to look at my face any longer than is necessary. Great. I hope everyone can see that. I put this slide up because those of you who are old enough, and I suspect many of you aren't, will recognize this as the MASH hospital. I grew up in the 60s and 70s, and MASH, which started in 1972, in some way inspired me to join the Army Medical Services. And really, over the 35 years of my career since then, things have moved on considerably, and that's really what I want to talk about today. So my purpose is to try and describe the key differences between the military and humanitarian health services in conflict and other settings. I'll focus on conflict, and I thought I'd use the example of the liberation of Mosul in 2016, 2017 to highlight some of the points I want to make. You know, this talk might usually take me an hour, so I'll try and condense it for you. But why does it matter? Well, it matters because it's common. Vast numbers of people have been killed and injured over the last 20 years in conflict, and it's predominantly civilians who are the casualties of conflict, even though the parties taking part may be the military. And injury and mortality in populated areas has become of increasing concern, particularly with the conflicts we've seen recently in Iraq and Syria. But not just there. You'll see bottom of the slide, it happens in all the places where you would expect it, most recently increasing numbers of people being killed in Yemen. But in populated areas, 90% of those killed are civilians. We often hear about the use of military weapons in populated areas. Does it matter what weapon is in use? Is it artillery, rockets, air-delivered weapons, helicopter-delivered weapons, barrel bombs? The answer is yes, it does matter. But you'll see that more than 50% of people killed in civilian areas were killed by improvised explosive devices, which have become a feature of urban conflict over the last 20 years. Really started in earnest in Iraq in the early 2000s, but it has become the weapon of choice for armed actors in many areas. Air-launched, ground-launched, they may be opposing military forces, they may in fact be the military forces of the country where the conflict is taking place, another sad development. But it doesn't matter to those on the ground. The bottom line is that 90% of those injured in urban areas continue to be civilians, and that's where we at Southampton have started to turn our attention. I said I'd use the example of Mosul. Many of you, hopefully all of you, will remember in 2016, a concerted international effort was started to liberate Mosul, the last, one of the last strongholds of ISIS control in Iraq, a city of almost 1 million people at the time, and the battle to liberate Mosul has been compared with the Battle of Stalingrad. I don't think it does bear comparison, but it is the most intense urban conflict of the 21st century. And essentially, it was a decision made by the Iraqi government, supported by Kurdish forces and a quite large coalition of international allies. But most of the fighting was conducted by national forces. The Iraqi government remained in control. They were advised by many others, principally American, UK, French forces. But the international forces didn't take such a big part in the ground conflict, but they did supply an awful lot of the artillery and air delivered support, which of course, as highlighted, does lead to an awful lot of casualties. So it started in October 2016, and it was not an easy process. And by January, as with all urban conflicts, it had started to become congested and blocked by the vast numbers of civilian casualties and the movement of civilians out of the city, largely eastward, away from ISIS forces. And what I've put here is just an example of a rather more military pattern describing where care occurs. Care occurs at the point of injury. People who've been injured are usually evacuated in all scenarios, whether it's on the streets of London or the battlefields of Iraq, evacuated by some form of vehicle, ambulance, some means to what we call role 1, first point at which care is delivered, and then onwards to what in military terms is known as role 2, where life-saving and limb-saving surgery is normally conducted. And then they would be evacuated to what we call the role 3, which would be a stable hospital. In UK parlance, that would be the National Health Service. In most countries, it would be a national or a military hospital, but that is where casualties would receive definitive care. And I stress this role 1, role 2, role 3, because it is important when we start to consider how the military or a humanitarian actor might operate in a conflict zone. By January, it was clear that the Ministry of Health in Iraq was not going to be able to cope. The hospitals in Mosul were largely destroyed. There was a degree of military provision, both from Iraqi forces and from coalition forces, but none of the coalition forces had committed any medical support to the conflict. And the NGOs that were operating there, principally MSF at the time, were not just reluctant, they were not going to engage with the military and didn't want to be seen in any way to be parties to the conflict for understandable reasons. None of the formal parties to the conflict, those military forces participating, were prepared to commit medical assets, again, for reasons which I'll come on to. And by January, it was apparent to the Ministry of Health and to the World Health Organization that no one was going to step in. So the WHO stepped in unusually as the provider of last resort. And that's where I became involved, because they didn't have, the WHO doesn't control any medical assets. And they approached me and asked whether I could help them to put together basically a trauma support capability. But of course, the WHO didn't have the capacity or the experience to conduct any integrated planning. What do I mean by that? Well, I described the process of casualty stabilization and evacuation, first aid, movement to a trauma stabilization point, movement to a field hospital, and movement onwards to a tertiary referral center. In this conflict, the tertiary center was in Biel, several large hospitals there, but by January, the evacuation chain, which I'll now call it, had become almost completely clogged by mainly Iraqi battle casualties. And quite understandably, the government was very keen to look after its armed forces to maintain the momentum in the conflict, and civilians were being managed really as an afterthought if they were able to make their own way to Erbil, which was 100 miles away, and there was no obvious transport route. People had to make it under their own steam. But the whole point about the military approach to a casualty evacuation chain is that it is joined up. People know who's responsible for doing what. Each part of the chain can talk to the next part of the chain. The patient, in military terms, moves seamlessly from one point to the next. So why can't the humanitarian agencies do it? Well, many of you will have worked with them and will understand their principles. Their core principle to save life and alleviate suffering, and supported by their commitment to humanity, but it speaks for itself. Impartiality. They must never be seen to be part of the politics of the conflict, and they guard their neutrality with huge intent. They will not talk, and neutrality is important because they operate by the consent of the various factions, and MSF and the ICRC are absolutely rigorous about this, which is why they will never be seen to be linked to any particular military force. So their independence is hugely important. They have guidelines, obviously. UN OCHA has become increasingly important in understanding and managing the way medical support is provided in both humanitarian emergencies and in conflict. And they stick to the Red Cross Code of Conflict. Unfortunately, the Red Cross Code of Conflict and the Geneva Conventions have increasingly been ignored in recent conflicts. And you will all know that there is a completely separate strand of work that we could talk about regarding attacks on medical facilities. And attacks on medical facilities are unfortunately a feature of conflict these days, because by attacking the medical facility, you undermine the will of the population to continue resisting. And that is a tactic used by many actors nowadays. But humanitarian agencies rely on their neutrality to gain access and to get protection. They operate in all sorts of conflict contexts, but very few of them have the capability to operate in a conflict zone, and none of them really have the capability of putting together a full chain of treatment. They also are very independent, and they lack unity of effort. They very rarely come together. One of the few times I've seen humanitarian agencies really work in concert was during the Ebola crisis in West Africa, when there was an awful lot of cooperation. But generally they compete for resources, for grants with each other, because they're funded by governments and international community bodies. And as you know, getting money out of them is difficult. There is this issue about to whom they are accountable. On paper, they're accountable obviously to their donors, but principally they're accountable to the beneficiaries. And that again is an area where it's very difficult to work out how to measure and deliver that in a conflict zone. Compare this to the military. The military has a core purpose. Its core purpose is to preserve fighting power. I'm talking about the military medical services. That means maintaining the health of the armed forces and treating, evacuating, returning to duty those who become injured. It's underpinned, the military is underpinned by very strong policies and doctrine. They spend an awful time writing it so that everyone knows what they're supposed to do. And in any conflict, they will always have a mandate, an objective to do a particular thing underwritten by political and military objectives, from which it's quite difficult to deviate. And they will deliver a completely comprehensive approach. That means that they will be prepared to treat people along the whole route of evacuation from point of injury through to return to a fixed hospital. In the UK, for example, that would mean someone who was injured in Mosul would receive treatment at various stages, but would within 12 hours have been flown back in a flying intensive care unit to the core hospital in Birmingham, returned to the care of the National Health Service, and then receive their ongoing care. So it's a complete chain of care. They're interoperable. That means they operate with allies, anyone else who is providing support. They can speak to each other. They speak the same language. They use the same doctrine. They can use the same logistic support. They take a capability approach. That's a very military concept, but it basically means that you look at what we call all the lines of development. You don't just need people and equipment. You need people with the right equipment, training, the right experience, the right information systems to collect data, to manage patient information, the right doctrine and policies, the right organizational structure, the right infrastructure, which doesn't just mean tents, it means water, it means electricity, and the right logistic support. The ability not just to deploy with your equipment, but to make sure you replenish it as you go. They're always responsible for their own security, and in the Mosul type of setting, it would have been hugely challenging to provide not just military medical facilities, but also to guarantee their security. And no government will deploy forces into a conflict unless it can, at least to some extent, guarantee their security. They work in alliances and they have a very clear chain of command. They respond to that. They don't operate outside of national governments. Remember, I said at the start that in this conflict, the Ministry of Health and the Iraqi government were in charge. And that is true for most humanitarian emergencies. National sovereignty must be respected. The military has to agree with national governments how they will operate. They're very hierarchical. They can be incredibly obstructive in the way that they stick to their own rules. And they do compete for development funding nowadays. Even the UK government will start to use some of its aid funding to support humanitarian efforts conducted by the military. Key point is they work within eligibility matrix. They have a core purpose, as I said, which is to look after their own, but they will always have rules by which they can treat other people, mainly civilian casualties, either those who've been injured directly in the conflict or those who managed to make their way. So, for example, during the 15 years of conflict in Afghanistan, UK, US, NATO forces treated many hundreds of thousands of civilian casualties of that conflict. And the key point here is that the military doesn't just provide hospital care for their own people, they provide a continuum of care. But for those who enter their medical chain, principally the hospital, from the civilian community, they have to be returned somewhere. They're very rarely evacuated out of country. And so the linkages into national facilities are very important when you're looking at taking on casualties. And that's one of the most complex areas, which is the management, the handing over of casualties from military facilities into civilian facilities, usually run in places like Afghanistan by NGOs, MSF and Emergencia, the Italian NGO, very prominent in that conflict. In Iraq, it was very much a question of national provision. The military are very good at the thing that NGOs are very bad at, which is data collection and analysis. And there's a big question mark about accountability because they're accountable to their own national governments, and they don't have a very good understanding of what the humanitarian world means by accountability. So if we look at this conflict, I put these pictures up really just to show what continuity of care means and what the humanitarian agencies can't do. You know, evacuation by helicopter, what we call emergency response teams, is just a no-go for most humanitarian organizations. The quantity and quality of surgical expertise is unmatched, even though the ICRC and MSF do have some very competent people. They can't They can't deliver and maintain them for prolonged periods in most cases. And nor does anyone else have the capacity to put up the sort of complex that I show in the bottom right of this slide. But it takes a long time to put any kind of medical response in place. And the sad thing about the Mosul conflict is just how stark the casualty figures are before any meaningful intervention took place. You know, I said it became apparent in January there was a problem, civilian casualties mounted, and by the time a trauma response had been delivered in April, the peak of civilian fatalities might well have passed, but there was still an awful lot of people being injured after that. What are the main challenges on the ground that a humanitarian organization might face? Well, most lives are probably saved during the first few minutes and hours in the first response, which is hugely disrupted, particularly in urban conflict. Infrastructure is destroyed. There are very few people with either the training or the equipment to deliver first aid in situ. It's very difficult to find casualties. You don't know where they are. This is where people like the White Helmets have done such a good job, because they set up an infrastructure that allowed them to communicate and access casualties. The local facilities will have been comprehensively destroyed, as you see the hospital on the bottom left, although it's remarkable how these facilities can continue to operate. And of course, it's very difficult to evacuate if you either can't get out of the conflict or you have nowhere to go. And one of the big challenges was not just the casualties, but the sheer numbers of people who were fleeing the conflict, who may or may not have required care. And something which I haven't highlighted here, which was a real feature of the Mosul conflict, and one of the real priorities for the WHO and the UN, was how do you provide care to pregnant women and young children? Because that was one of the features of the emergency response, the provision of emergency obstetric care. And in addition, you have what we call a mixed evacuation chain. You don't just have displaced people, those fleeing the conflict. You have the injured indigenous forces. So the Iraqi military didn't have a very sophisticated evacuation chain. And mixed in with them, you have enemy combatants who are not wearing a uniform that says, look at me, I belong to ISIL. And at some stage, they have to be separated. They provided a huge threat to the security, because they would turn up in medical facilities still armed with improvised explosive devices, either in their vehicles or on their person. And it's very difficult then to conduct meaningful triage if you, first of all, have to make sure that your casualty is not a threat to you. Triage, you know about, it is basically the process of sifting casualties depending on the severity of injury, assigning priority for treatment, and importantly in this case, separation of combatants from civilians, own force combatants and enemy force combatants and civilian casualties. And ultimately, like it or not, they will be treated slightly differently, even though medical principles say treat according to need. There will always be a degree of choice. And then there's the provision of life-saving surgery. In the early months of the conflict, many people died before they got anywhere near to a surgical facility. And those who were providing some of that surgery may well have lacked some of the specialist knowledge that the military spends so much time acquiring and preparing for. But as I said at the bottom, key priority was to maintain a health service for the most vulnerable. And the organization I worked with managed to deliver 2,000 healthy babies during the 3 months that they were actually operating in this environment. I think I was given 20 minutes. I hope I've taken only 20 minutes. I will stop there and take any questions either now or at the end.
Thank you, Michael. I think we'll do questions after the next speaker, and so if anybody's got any questions for Michael, if you can put them in the Q&A chat or note them down, and there'll be an opportunity to ask your questions after the next speaker. So thank you very much, Michael. I'd now like to introduce Professor Christiana Andrade, who's a researcher at Fiocruz University and is focusing on teaching and research about violence, work and gender. She's also an advisor on the Masters in Public Health. So Christiana, over to you.
Thank you very much. Good afternoon to everyone. I'm a public health at Fiocruz Health Ministry, and I have a postdoctorate in nursing and advisor in master public health. I'm studying about the work, gender, migration, and violence in Brazil. So thank you very much for inviting me to present our experience with the course, The Health Impacts of Violence. So I'm a Brazilian woman, and in Brazil, we don't speak English, we speak Portuguese. So I'm so sorry for my accent. And I'm speaking very slow, okay? So I'm responsible for presenting our experience in the construction and development of this course of healthcare professional. My department created this course to contribute with the 4 professional training health professional. And the objective is to increase their knowledge. Because of the pandemic, we saw the necessity of the community to have a support in some areas. So this course supports healthcare professionals in caring for people who suffer violence. The impacts of the pandemic in our society was crucial to understand, because we saw the necessity to help the professional healthcare. In Brazil, unfortunately, people don't have money to pay a professional to help them. And now, so can you see the slides? Next. It's possible to see?
Yes, we can.
Okay, thank you. This course has a partnership with the Ministry of Health and with the Department of Health Surveillance, and with my school, Serjaroca National School of Public Health of Oswaldo Cruz Foundation. In my department, is the CLAVES, Department of Violence and Health Studies, Jorge Carelli, and with a partnership with distance education, because the course is online. And we have a big team to do this course. The coordination CLAVES, we have Katinjane, Simone, Patrícia, Joviana, and Joviana and Patrícia are learning advisor. And we have the support, a big team with Diogo, Elizabeth, Leonardo, Marcelo, and the SEAD ENSP is with Maurício, Alex, Antônia, Henriette, Paula, etc. We have a big team for the tutors and teachers too. I think we have 18 teachers or tutors, because we have a big team of the students. Here, this is my colleague, Katinjane, etc., etc., etc. And here you can see the maps of Brazil and each states. In this year, we have the total of the 198 students. And you can see each state and the number of the students. Like in São Paulo, 28 students. Rio de Janeiro, we have 23 students. And the next I can speak about the most of students are professional in these years, like social assistants, doctors, nurses, psychologists, occupational therapists. The course is an important strategy for the implementation of the guidelines of the national policy for reductions of morbid mortality from accidents and violence in our country. It's a policy about the accidents and violence, and this moment we are doing research about the implementation of the disease policies in our country, and in 27 states of Brazil. It's a big research with a questionnaire, with interview. So it is here the national policy to reduce the morbidity and the mortality from accidents and violence celebrates 20 years. In this case, the need for training health professionals in the area of violence and health is growing and has been a demand of professional themselves, service management, and the Unity health system. In Brazil, we say SUS, Sistema Único de Saúde. And about our course, the specialization in impacts of the violence in health, the objectives are to train health professionals at all levels of care to deal with issue of violence and its impact on individual and collective health. And the other objective is to promote reflection and dialogue between health professionals and teams about their experience in caring for people in situations of violence. And the other objective to expand the capacity of institutions and professionals in the care, surveillance, and prevention of violence and local level. To provide the implementation of the national policy for the reduction for accidents and violence, and of the health promotion policy, and all actors relate to the prevention of violence and the promotion of life in the country. And about my department, we have department boss, Katia Nijani, we have a teaching coordination, Joviana, and a research coordination, Patricia, and me, I am a technical and social cooperation coordination with my colleague, Ednilza Souza. My department it's a research, teaching, and advisor center created in 1988 with the objective of investigation the impact of violence on the health of Brazil and Latin American population. We have many partnership in Latin America too, with university, and others collaborate. We collaborate with governmental and international bodies, scientific societies, and civil societies. Conducts interdisciplinary, interinstitutional, and intersectoral research. And we can do the support the public policy in Brazil and Latin America, with the elaboration of action plans and policy in area of accident and violence for the Ministry of Health, through the health surveillance and healthcare secretaries. And you can preparation of action plans with the Special Secretary for Human Rights. Advice and consultancy to states and municipalities and the Council for Creation of Security and Violence Prevention Policies, advise to state and municipal health departments aiming at prevent violence and promoting quality of life and citizenship. And about the human research, we have a master and doctorate in public health on violence and health. We have a master and doctorate in humans and children health on violence and health too. We have distance course impacts of violence on health is about its course that I said. Specialization, improvement, and update. We have other course impacts of violence at school is a specialization to teachers at school, and we have two semi-attendance courses confront violence at school. We have students of the scientific initiation, specialization, master and doctor students. And how about the research stems? You are working with the theme like as violence in different stages of life, children, teenagers, adulthood, elderly people. We have research about the gender violence, violence arising for sexual orientation, violence and social, class, gender, ethnicity, race, and age inequalities, violence at work, workplace violence, bullying at work, violence and mental health, violence, migration and refugee, violence against institutionalized people, epigenetics and violence, evaluation of programs and services for people in situation of violence, information, communication and violence, digital sociability and violence, accident and violence information system, in road traffic injuries and deaths. So thank you very much. If you can questions, put in the chat and you can talk about it.
Thank you very much, Christiane. So we'll now start the Q&A session. So please raise your virtual hand if you'd like to ask a question verbally, or use the Q&A box. And so the first question we will put is from Catherine Campos, and it's to Michael von Bertele. So, hi, Dr. von Bertele. What do you think can be done today to implement increased collaboration between local and humanitarian actors on the ground to strengthen surgical capacity in conflict settings?
Thank you, Catherine. I think the most important aspect is training in the first instance, and there are a lot of initiatives underway to assist people in training. You probably or may be aware that the management of injuries of conflict is a particular specialty, particularly the management of what we call high velocity wounds, those caused by bullets and high velocity fragments, which are very different to those caused by slow velocity wounds. So typically car accidents and stabbings and assaults are low velocity injuries. High velocity injuries caused by fragments and bullets cause particular harms and mount particular challenges, and very few civilian practitioners have experience in managing those injuries. And there are a number of courses around the world designed to both train people to treat those injuries, and a number of initiatives where experienced clinicians go out to conflict areas where it's safe, notably places like Gaza, to assist in the training and management of complex injury. So there is quite a lot going on, and I think training and raising awareness is probably the most important thing that can be done.
Thank you very much, Michael.
So we have a raised hand from one of our participants, Sonu Basker. You have your hand raised. Would you like to ask your question now?
Thank you, Jack. And the question is for Michael. I'm logging in from Sydney in Australia. Like one of the important aspects of conflict settings is beyond the human resources, it's also about local innovations. Now, building surgical capacity by increasing the influx of well-trained physicians on ground should be complemented with local innovations which are cheaper and cost-effective. Now, what can we do in terms of supporting innovations that can be used and applied on ground? Thanks.
Yeah, that's something that vexes the humanitarian community generally in response to crisis. And the answer is always going to be putting some effort into planning and preparation. So it's very difficult once the problem has arisen to do anything about it. And so even in developed countries, the UK, US, there are initiatives, for example, in training people in advanced first aid, or just a degree of first aid, telling them what they should do if certain things happen. One of the biggest advances in recent years in military medical support has been the recognition that what kills people is not just the blow to the head, the loss of consciousness, but it's actually the catastrophic loss of blood. And the hugely increased use of pressure dressings, of hemostatic dressings, and of tourniquets, and the provision of those things in first aid kits and teaching people how to use them certainly made a massive difference on the battlefield, and will make a massive difference if applied on the street. So training and awareness and the use of tourniquets and the appropriate dressings is probably the single most important thing on top of the normal first aid training. In terms of other local innovations, I think impressing on, well, planning of emergency response is important, and ensuring that your local medical facilities know what to do. But the challenge is, as ever, getting patients to hospital, and the evacuation of someone who's been injured to hospital is a waste of time if they bleed out on the way. So again, understanding when it's safe to move someone, trying to make it safer for them. I can't think of any magic bullet, however, that would assist, although tech devices are being used to monitor physiological status, so you can assess whether the urgency of someone's condition by looking at their pulse, their blood pressure, their state of oxygenation. And more people have those physiological monitors either on their watch, on their smartphone, with the ability to transmit that information. So things like that are important, but it all comes down to awareness and training, and then to the provision of simple, cheap, easily usable equipment like the dressings I mentioned.
Thank you, Michael. We have a question that was submitted before the webinar for Christiane. So the question is that we have a lot to learn about how to conduct research on mental health, particularly in areas of violence. How do you counter this, and how do you obtain consent from participants and go about determining sampling and sample sizes, as the person who asked the question perceives a lot of replacement of participants and uncertainty if people will be able to participate throughout the whole study? Have you got any thoughts on that one?
I have to say about the scenario pandemic, because we have, for example, in the point of view of the health professional, inadequate work conditions and inadequate conditions to healthcare. And we have to less investment of public. And so we have a big problem in our society, because the increase of the violence is not same the increase of the preparation of the working health professional. For example, we have the SUS, our system of health, but the SUS don't support the attainment of health, mental health for women, for children, for example, and the elderly people. And we have an increase of the cases of the suicide, for example, and the increase of the mutilation self in teenagers and the adulthood too. I don't know if you I say correct, but if you possible to put in the chat, I can write correct. Okay.
Okay, thanks very much, Christiane. I think we have time just for one more question, if that's okay. This question is for Michael von Bertele. The question is from Roderick Bailey asking, could you say a few words about the challenges of blood transfusion in a conflict environment such as Mosul, and any particular problems or issues that you may face the military medical service may require suddenly or urgently? Such as, for example, providing large amounts of blood to civilian casualties, including women and children. So that's a question for Michael von Bertele, if you're still with us. I'm here.
Yeah, you might call this the universal problem as well as the universal blood type. I'm sure you're aware that in an emergency setting, you can only give one type of blood if you don't have the facilities to cross-match it. So the first point to make is that O-negative blood is in huge demand, and there's not enough of it because it's quite a rare blood group, but the military will always try and collect enough O-negative blood. The military is able to do cross-matching quite quickly these days and do deploy laboratory facilities, but there will never be enough blood. We have what we call mobile blood banks, which are otherwise known as soldiers. So you can pre-test people, but there are challenges in that. If you're going to pre-screen people for viral disease, for example, there are ethical issues. So in a conflict setting, what you really need to do is get people to volunteer to donate blood. Once things are stable enough, there's never a shortage of volunteers, but it's usually very difficult during the peak time. So what can you do? Well, there's been an enormous amount of research over the last 30 years to deliver the two things which blood does. Blood carries three things, actually. It carries oxygen, it provides circulating volume for all the other stuff that goes around the body, and it carries clotting factors. And so if you've been injured, you probably need all three of those things. You need to replace the volume. You can do that with other fluids, as you know, but you can't improve the oxygen carrying capacity either without giving blood, or a lot of research has gone on over the last 30 years into producing blood carrying substances, either hemoglobin based, what are called HBOC, hemoglobin based oxygen carriers made from human hemoglobin or animal hemoglobin. None of those have ever been properly licensed for use in people, or other chemicals, fluorocarbons that will carry oxygen. Again, very tricky, but a lot of work is going on to do that. And you can produce clotting factors, you can isolate those and give what are called platelet. You can isolate the platelets from the blood and deliver those, and they don't have the same challenges of cross-matching, although you still have to be careful. Some of these things can be frozen, but again, it's very difficult to to prepare them then for infusion in a conflict setting. So it continues to be a challenge, and the best option in most resource limited settings is to get relatives to attend the hospital with the patient, and usually one or other of them is found to be a match, or the extended family is found to be a match. And so there's no substitute for live, fresh human blood in those resource limited settings.
Thank you very much, Michael. I think that's probably all the time we have for questions today. For those who have asked questions that have not yet been answered, they will be given to the panel, and we will ask for a written response, and that will be circulated after the webinar. So I'd like to take this opportunity, excuse me 1 second. To share with you a new venture, which is the Global Consortium for Injury Research, which expands on our already established network, the International Blast Injury Research Network. So the GCIR has a vision of bringing together a consortium of people working in injury research across all injury areas. We are a collaborative open access knowledge hub where researchers, health workers and others can network, share resources and work together. The GCIR aims to address the global issues of injury through multidisciplinary research, including clinical, engineering and public health approaches to facilitate collaboration between academia, defence and humanitarian organisations. So our work mainly focuses on generating evidence to address global injury issues through academic research, priority setting activities and promotion of research uptake to improve health outcomes.
So the GCIR, it aims to facilitate and coordinate multidisciplinary research efforts and collaborations between different stakeholders who are all concerned in areas of traumatic injury. And we're particularly focusing on different thematic areas. This includes blast injury and mine action. Now, this is an area that Becky and myself have been working in over the last few years. But we're also focusing on road traffic accidents and gun violence. So what we'd like to say today is if you are interested in collaborating, or perhaps you're already involved in these activities relating to these thematic areas, we'd really welcome your input and your collaboration. So a website to the new hub will be linked in the chat shortly, and we'll circulate this with the recording of today's seminar. So we are unfortunately running out of time, and we'd like to say thank you very much for your participation in this webinar today, and also thank you very much to the panel. We've received some interesting comments and questions. We've answered some of those. If we haven't, we will gather those, we'll circulate them with the panel and get some responses to you in writing. The recording of the session, along with any of the materials that have been shared today, we will send you a link and you'll be able to find these in the chat now. So finally, thank you very much again to the panelists, and thank you also for your participation. And that will be the end of today's session. Thanks very much, everyone.
Thank you.